So here we see some radiographs of the hand in the PA and also the forearm lateral. And the most striking finding is actually here within the soft tissues. We see all this calcification, sheet-like calcifications in the forearm as well as the distal posterior arm here next posterior to the elbow joint. And we see some periarticular calcifications. So in the hand here in the thumb next to the interphalangeal joint, and this calcification look cloud-like. They're not ossification, right? They don't have any bone marrow. It's just like calcific density, like a cloud, like chalk. And these are dystrophic calcification of the soft tissues, and we're going to discuss a little bit about that. So we're thinking here about the differential diagnosis of diffuse soft tissue calcifications like dermatomyositis, scleroderma, and other systemic illnesses that can give you these dystrophic calcifications. So this is PA views of bilateral hands on a different patient with the same condition. And we again see some soft tissue calcifications, and not as much as on the other patient. But something that we see here that is interesting is that first we have acrosteolysis. So several of the distal phalangeal tufts that we see here in bilateral thumbs and the index finger here, little finger here, there is resorption of the distal phalanx, and that is called acrosteolysis. And the other really interesting finding is there is not really that much soft tissue around the bones of the finger. Soft tissue resorption and atrophy. So this is a patient with scleroderma, which is systemic fibrosis, and you get fibrosis all over the body, and you have findings in the GI system, in the chest, and also the MSK system. But that resorption of the soft tissue is related to fibrosis and the loss of vascularity, and the acrosteolysis is similar to the pathophysiology of frostbite, although obviously not the same. But when you put together the calcification, the soft tissue resorption around the bones, and also acrosteolysis, you have to think about scleroderma. So talk a little bit about scleroderma, systemic sclerosis, deposition of collagen all over the body. So here we're just going to talk about the MSK manifestations. So remember the subcutaneous and periarticular calcifications, not ossifications, just calcifications. You can see it around the hands and usually the appendicular skeleton, but they'll be all over the body. The acrosteolysis due to the fibrosis and soft tissue resorption of the first carpometacarpal articulation is common, and flexion contractures just because of the fibrosis as well. And regarding soft tissue calcification, it's good to remember the difference between dystrophic and metastatic. Thankfully, dystrophic calcifications are 95% of the calcifications we see in the body, so the great majority. And that only means that it's dystrophic because it's sequela from some type of insult to the soft tissues, either ischemic, inflammatory, traumatic, any tissue death or inflammation enough to cause damage of the tissue may end up in calcification. And that's what we call dystrophic calcification, which is the ones we see in scleroderma. We see some soft tissue death, and then it ends up in calcification. In metastatic, it's the only 5%. And obviously, if you have the clinical scenario with the patient with chronic renal disease and some abnormality in the metabolism of calcium, you can think about metastatic disease, but usually the clinical history will help you with that. So in conclusion, when you have a calcification, you know that 95% is going to be dystrophic, and you just have to figure out what happened to that soft tissue that it ended up dying or getting enough inflammation that it ended up in calcification. So here we have two ultrasound images, longitudinal and transverse, of the distal leg on a children with swelling, looking for soft tissue abscess. And here we see the tibial bone here, and very echogenic, and nothing is seen distal to it because the ultrasound wave is completely absorbed by the bone, and that's why ultrasound is not good for evaluation of osteostructures. You can only see the periosteum or superficial cortex. But besides that, we see next to the bone this kind of complicated fluid collection, because there is some echogenicity inside that. And it's not, we describe it as a supraosteal abscess, which is what it is, but notice that there is not really any abscess within the soft tissues themselves. It's actually like part of the bone, You can see where the yellow line is some echogenic part of the periosteum, giving us the impression of supraosteal abscess, which you can see in ultrasound. And in this patient, we recommended an MRI. In the MRI, it's much easier to see. We have the distal tibia, and we see this large kind of high T2 signal intensity collection, which is pus, between the bone of the tibia and the periosteum. So it's a subperiosteal abscess. And this happens in osteomyelitis of the children. Osteomyelitis is right here all throughout the distal tibia. And the periosteum is kind of loose in children as compared to adults. And the periosteum has actually two layers. Has a fibrous superficial layer out here. And then it has a very vascular layer opposed to the bone. And usually infection goes from the metaphysis and it extends right here into the periosteum, and because it's loose, the pus kind of gets between the fibrous and the vascular layer and creates that abscess. That vascular layer, which contributes to the membranous bone growth, is the way that the infection propagates really fast, because it's all vascular and the infection just can go, in this case, proximally. The note that is important in this type of supraosteal abscess that it doesn't cross into the epiphysis. There's the perichondrium here that creates a V. It's called the vertex, and it stops the progression into the epiphysis, which is a good thing, because in most cases all this pressure goes to the supraosteal space and doesn't go into the articulation, creating a septic arthritis. So supraosteal abscess, you're going to hear this a lot in the orbit. That's usually where it's very common, associated to sinusitis. But in the children, it can happen in the extremities, and it's very common with osteomyelitis. Kind of a common complication, and you can see in ultrasound. That's why sometimes it comes in the test, because you see this ultrasound image of a supraosteal abscess and you're thinking, well, you can't see anything in the bone on ultrasound, but you can see a supraosteal abscess because the fibrous layer of the periosteum is so thin that the ultrasound waves can cross it, and we can see a representation of that. So we already described the two layers, superficial fibrous and the intervascular, which helps in the propagation of infection. Stopped by the perichondrium, which shows that V next to the growth plate. It's called the vertex, where it forms that V. And it stops the progression of infection into the articulation, something that's good to remember. And this needs to be treated and drained, because the periosteum in children contributes to the blood supplies and membranous growth. We already said that, the inner vascular layer. So it can end up in bone necrosis and growth disturbances. So it actually is kind of an urgency and needs to be treated. All right, so we have here axial and coronal images of the thighs and T2 with fat suppression. We have T1 and we have T1 fat suppression with fat suppression and post-gadolinium. And the most striking finding is that we see patchy edema, high T2 signal intensity in the anterior and posterior muscle compartments of the thigh. And the T1, we basically don't see anything. There's really not enough atrophy to see fatty infiltration, but in the post-gadolinium images, we see that there is a diffuse patchy enhancement throughout the muscles that we see. So we have edema and enhancement of the muscles. Patchy, there's not really like a localized region of enhancement that would suggest a mass or a focal inflammation. So this is just diffuse inflammation, and we're thinking about myositis, obviously inflammation of the muscle, in a systemic process, and we see this commonly in dermatomyositis and polymyositis. In fact, the rheumatologist will order just thigh MRIs just to see if there's inflammation, and what we're looking for is either muscle edema or muscle atrophy. Muscle atrophy will be chronic findings of myositis because the muscle just gets atrophy after so much inflammation, and you can see that with fatty infiltration. And in this case, will be a good time to do a punch biopsy for evaluate the myositis because of all this enhancement. So it means that the myositis is active. So just to compare to the other case we saw earlier, this is a patient with dermatomyositis but chronic, and we see all this calcification throughout the soft tissues of bilateral thighs and proximal legs. They don't have really any classic configuration, but this is a patient with dermatomyositis, and it's Similar to the one in scleroderma, where you have systemic calcifications, in dermatomyositis will be more common at the proximal thighs or proximal muscle groups, like the MRI that the rheumatologists order. And again, it's a dystrophic calcification. It's caused because of the diffuse myositis and inflammation of the soft tissues that end up dying and calcifying. Also in MRI, as I said, you could see fatty infiltration or increased T1 signal intensity within the muscle, which means that it's atrophy. But too much death can end up in calcification, and diffuse calcification in the soft tissues is something we also see in dermatomyositis, but in the chronic phase. So quickly talk about myositis and the differential diagnosis, or at least the pathophysiology. So it can be inflammatory like dermatomyositis, but it also can be infectious or traumatic. It can be drug related to statin treatment. Radiation myositis is very common, but it will be very specific to the region of radiation. And chronic myositis, again, is similar to chronic denervation, where we have that fatty infiltration. So those are the things we're looking at in the muscle when we're looking for dermatomyositis. Edema, an enhancement, fatty infiltration if it's chronic, and in radiographs or CT, try to look for soft tissue calcification. So we have AP and lateral radiographs of the knee in a skeletally immature patient. That is important to notice, with the open growth plates, and we see that there is an ill-defined, mostly lucent lesion within the medial tibial metaphysis, better seen on the AP view than on the lateral view. That's because, at least in radiograph, the lateral proximal tibial metaphysis looks somewhat normal, and that is they're superimposed on the lateral view. So this lesion looks aggressive, right? If I take my pen, there is no way that I can trace a line and say, okay, this is where this lesion starts and where it stops. It's very wide. So the zone of transition between the lesion and the good bone is very wide. You can't really say exactly where it is. And that is a classic sign of an aggressive lesion of the bone, because it's growing so fast and it has so much inflammation and increased vascularity that the osteoclastic activity, which are the cells that eat up the bone and create that lucency, are completely beating the osteoblasts, and the osteoblasts have no time to just put a response. So that's why the zone of transition is wide. Also, of course, it's lucent, and you don't see the cortex in the peripheral aspect of the medial tibial metaphysis is almost imperceptible. So that is almost like cortical breakthrough, which is another sign of an aggressive lesion. On the lateral view, we see some subtle calcification anterior to the tibia, and that's some matrix. So this lesion is creating matrix. A young patient, pediatric, aggressive lesion. Even without looking at the images, you should always think about osteosarcoma or Ewing sarcoma, osteosarcoma being more common. And you see this bone production or osseous matrix, and you should favor osteosarcoma. And this is a classic osteosarcoma as seen on a radiograph. Just to have an idea, we have an MRI with coronal T1, T2 fat SAD, and T1 fat SAD post-gadolinium. And the lesion here is actually more prominent, and looking in the T1, it actually looks like it's well defined. You can actually trace a pencil around it. In the T2 and T1 post-GAD, it's not that well defined because there's so much edema and inflammation on the bone that you can't really see where it starts or where it ends. So that's why we still use the radiographs to describe the behavior of lesions in the bone, because it may be a little bit deceiving on the MRI in terms of the border. But we can see there's cortical breakthrough here medially, and we can see there is some regions of necrosis. So a very aggressive lesion, and we usually do MRI for staging, see if it's crossing the articulation, see if we see any skip lesions here in the distal femur, or across the articulation, or anywhere in the bone in the tibia that you could see. So osteosarcoma is a fairly common of the primary bone tumors. Primary bone tumors are not very common, but of those, osteosarcoma is pretty common. It's the second most common. Conventional osteosarcoma is the most common type. There are others, but conventional is the ones that we usually see in children. Secondary osteosarcoma, we see it after radiation or Paget's. Very important in radiation. Usually, like if I've seen plenty that females that have cervical or GYN cancer and go through radiation, And 10 years, you can count on that, 10 years after the radiation, they develop a bone lesion, and it's usually post-radiation osteosarcoma, and it's usually around 10 years. And Paget's is the pagetoid bone predisposes to the development of secondary osteosarcoma. It can happen everywhere, intramedullary, which is the most common, but we have surface osteosarcoma, intracortical osteosarcoma, and even extraskeletal osteosarcoma. Remember aggressive bone lesions, the white zone of transition, the osseous matrix, is that a cloud-like formation of bone, as opposed to we have fibrous and chondroid matrix, but the osseous matrix looks like cloud-like, just like the calcification that we saw in scleroderma. It's just this chalk type, no osseous, no bone marrow formation within this soft tissue calcification. And aggressive periosteal reaction, that's where we see the Codman triangle, sunburst, and all those aggressive periosteal reactions we can see in osteosarcoma. Remember, for your life and for the test, if a biopsy is consulted, make sure that orthopedic oncology knows about it. Sometimes they want to tell you exactly where to biopsy because they want to do a flap or they don't want to do any seeding, even though it's very, very, very rare to do that because we use a coaxial needle, but it's safer just to consult ortho-oncology. Here we have a case that we don't see much in real life, but it kind of is a frequent flyer on examinations because of the imaging findings are pretty characteristic. So we have axial T1 and T2 fat sat images of the wrist and some coronal on T1. And this here is the carpal tunnel. Here on red will be the part of the carpal retinaculum. And in green, I'm just gonna, it's the flexor tendons, some of the flexor tendons that we see here. And what we see is this big high T1 signal intensity lesion within the carpal tunnel that has some like little dots in the middle. They're called the cable sign, like little cables. And because we see it on the T1 is really high on T1 signal intensity, but then on the T2 fat suppressed image is really dark. We know it's fat, macroscopic fat. And this is the location of the median nerve. So this is, you got a lot of information here. You have a fatty lesion that lives within the median nerve or at the expected location of the median nerve. So we're thinking about, fatty lesions of the nerve, and there are not too many of them. And in the coronal images, we see this kind of enlargement of the median nerve here when it comes out of this region here. It comes out of the carpal tunnel, like kind of enlarged, and we see these little strands of the vesicles of the nerve. They almost look like spaghetti, which is actually called the spaghetti sign. So these are the findings that we see in MRI, and when you see a median nerve enlargement with fat, you should think about this condition, which is very common on the test. So here we go. We're talking about fibrolipomatous hamartoma. It's hamartoma. It's not a malignant lesion. It's a benign tumor of the nerves. We have with fat, fibroadipose tissue growth. There's fusiform enlargement of the affected nerve. It's usually in the upper extremity. And look, 80% of them occur at the median nerve. You can also see it at the ulnar nerve, but the majority is at the median nerve, and you're going to see a case within the carpal tunnel. Back in the day, in the exams, there was a common question of what was the conditions associated to the fibrolipomatous hamartoma. And it's macrodystrophia lipomatosa. And remember, it's associated to macrodactyly. So you'll see a large or enlarged finger associated to this tumor. In MRI, we saw that coaxial cable like in the axia, those little cables within the lesion on the T1, and the spaghetti string, which we can see in the coronal images. And the treatment for this is surgical debulking. So probably not a lesion you're going to see a lot in your clinical practice, but it is a frequent flyer in the test.